Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. We are disseminating the National Guidelines for HIV Care and Treatment 2021. These sessions are being conducted for the East Region ARTCs. Today's topic is diagnosis of HIV infection in adults and children and assessment of adults and adolescents with HIV infection. And the speaker is Dr. S.K. Guha, sir. Dr. S.K. Guha is the Professor of Tropical Medicine and Medical Superintendent cum Vice Principal, Program Director, Center of Excellence in HIV Care, and the Program in charge of the Postgraduate Diploma in HIV Medicine, IGNO, at School of Tropical Medicine, Kolkata. He is also the chairperson of the Technical Guidelines Revision Committee. He has many articles published on malaria, leishmaniasis, hepatitis, and HIV/AIDS in many national and international peer-reviewed journals. We welcome you, sir, for today's session and request you to start the session.
Good afternoon, everybody. Today we are going to discuss about the national guidelines for HIV care and treatment that was revised last year. In fact, this is going to be a repeat of the same session that was held last year, and this is for East region. There are two topics, as Shweta talked about. One is diagnosis of HIV infection in adults and children. And the second issue is assessment of adults and adolescents with HIV infection at the ART center. So let's start with sorry.
So you will have to click on the PPT. It must be at the bottom of your screen. Right. Right. So full screen mode, please. Okay. So just, yeah.
Integrated counseling and testing centers. It's not moving.
So please click on the slide and then next button on your keyboard. Yeah.
Sorry.
So I should share it from my end?
Yeah, that will be right.
Yeah, give me 2 minutes, sir, please. So is the screen visible?
Yes. So basically, as we know, HIV is a chronic manageable infectious disease which requires, as of now, a lifelong treatment for various conditions, including opportunistic infections, neoplasms, as well as the need for antiretroviral therapy. As you all know, we are starting antiretroviral therapy these days on a test and treat policy, where someone who is diagnosed to have HIV positive, he or she is immediately put on antiretroviral therapy without any further delay. That was the thing. Now, even then, still a proportion of patients that present to the clinical facilities or at the ART center or at the ICTC at a late clinical stage, where even after starting antiretroviral therapy, the patients often present with multiple opportunistic infections, and the mortality continues to be significantly high. So late diagnosis is an important factor which is associated for morbidity and mortality associated with HIV infection. As we all know, in the national program, we always promote HIV voluntary testing by individuals who are at risk of acquiring HIV infection. And at the ICTC, informed consent is always taken while doing the pre-test counseling. And then the blood samples is drawn and tested. And thereafter, the results are divulged by the trained counselors at the ICTC by doing a post-test counseling, both for positive as well as negative test results. Now, adults, adolescents, and children above 18 months of age, their HIV detection or diagnosis can be done based on antibody testing or by the viral testing like the PCRs for viral nucleic acids. However, in children, infants and children below 18 months of age, as we all know, that the passively transferred maternal antibodies may persist for 9 to 12 months, and in some cases up to 18 months of age. So, by detection of simple antibodies in the serum or plasma or blood may not be true indicator of actual HIV infection in the infant or child below 18 months of age. So there we need to go for a viral diagnosis, which is in our program is done by a qualitative PCR that detects the proviral DNA as well as the HIV RNA. So that's why it is termed as total nucleic acid test based on PCR. And then we need to remember it's a qualitative PCR, not a quantitative PCR that is done for HIV-1 RNA for viral load estimation. Next slide, please. So under the national program, we know that there are, these are all just a recapitulation of our old knowledges basically. Rapid tests are there based on principles of either ELISA or enzyme immunoassay, immunochromatography or lateral flow assay, immunoconcentration or dot blot assay or vertical flow, and particle agglutination. And these are the various, these are all rapid tests that are results are available within 15 to 30 minutes in a lab. So, and they are based on principles of such and such ELISA and immunochromatography, immunoconcentration, and particle agglutination. And what is the mandate of NACO is that all these rapid tests that are employed to be used at the ICTC must have a sensitivity of greater than equal to 99.5% and a specificity of at least 98% and above. So these are the specifications of the kits that need to be used at the ICTCs, and all the ICTCs in the country are actually using this such kind of kits only. And as we all know, when someone is infected with HIV, and if you go to test that person with antibody, there is a window where after initial infection, the antibodies takes time before the IgM antibody gets detected. It takes about 6 to 12 weeks time. So this represents the period between the infection with HIV, initial infection, and the time when the HIV antibodies can be detected in the blood. So a blood test performed during this period may yield a false negative results. So, and this may require further testing after 12 weeks. So if you ask someone how to get someone diagnosed at that point of time during the window period, it's not the antibody-based test, but the viral test, like the demonstration of the nucleic acid of either the HIV proviral DNA or HIV RNA. That can be done. Next slide. So this is, and considering that India is a very low prevalence state, the prevalence of HIV is much less than 1%. So in keeping with the global guideline, there in a low prevalence setting, at least 3 different principles or antigen-based rapid tests are to be used for confirmation of HIV diagnosis. And this is the strategy 3 that is being employed in our national program. All samples that are tested reactive in the first test should undergo further confirmatory second and third tests based on different principles or antigens. Principles that we have mentioned earlier on, that it could be immunochromatography or immunoblot or particle assay, etc., agglutination, etc. And this, remember that the same sample is being tested at the ICTC by 3 tests, not a different blood sample. So one sample is drawn, and that subject, if it is negative, it is declared as negative. If it is positive, then for the second and third tests are done. When all 3 tests are done, then they are all declared as. Am I audible?
Yes, sir.
Okay, someone has called up to say that I'm not audible anyway.
You're audible, sir.
Yeah, so I'm audible. So the same blood sample is utilized for performing all the tests. And for indeterminate results, you can come across cases. Suppose you test one test, first test is positive, and then you go for a second test. The second test is also positive, and you go for the third test. Suppose the first and second tests are positive, and the third is negative. You call that indeterminate. Or if the first test is positive, the second one negative, and the third is positive, so 2 out of 3 is positive, then you call it indeterminate. So for indeterminate results, the test has to be repeated on a different sample after 2 to 4 weeks, or in other words, 14 to 28 days later on. Next slide, please. Next slide, please. So this is actually the testing strategy of our NACO that is being followed at all ICTCs for clinically asymptomatic patients. As I said, the strategy 3 is employed, where the assay 1 is A1. Interpretation is if the test is negative, A1 negative, then you report negative. If it is positive, go for the second test, A2 or assay 2. If A1 positive and A2 positive, then you go for the third test, A3. And if all 3 tests are positive, A1, A2, and A3, then report positive with post-test counseling. This is the interpretation. And similarly, when the A1 is positive, but the A2 is negative, you go for the third test, A3. If A1, A3 positive and A2 negative, then once again you call it indeterminate. But if only A1 positive and A2 and A3 negative, then you need to look into the profile of the client or the patient. If he or she belongs to a low risk, then you consider it to be a negative. But however, if you belong to a high risk, if it's from the key population, then you consider it to be an indeterminate and repeat after the test should be repeated after 2 to 3 months. So summarize, if first test is negative or A1 negative, report negative with a positive or with a negative post-test counseling. If it is positive, then go for subsequent tests, and out of 3, if 2 tests, if all 3 are positive, A1, A2, and A3 positive, report positive with a positive post-test counseling. However, if only A1 and A2 positive but A3 negative, or A1 and A3 positive but A2 negative, these are indeterminate cases where you need to report after 14 to 28 days. And in case where only A1 positive and A2 and A3 are negative, then you need to look into the profile of the client or the patient. If the patient belongs from a high-risk group or key population, then that test has to be repeated after 2 to 3 months, considering it should be considered as indeterminate for that patient population, because these are the patients who are vulnerable and get repeated exposure to such HIV positive sources, so they might turn out to be positive later on. But if he is from he or she is from the general population without any risk factors, you can consider only A1 positive, but the A2 and A3 negative, you can consider it to be a negative only. Next slide, please. So we have already discussed about this, the infants and children less than 18 months. So there, the maternal antibodies, as I said, particularly of the IgG class, they passively transfer to the placenta and they can persist up to 9 to 12 months and can sometimes up to 18 months. So children born to HIV positive infected mothers will test positive for HIV antibodies. So whether you use a ELISA or rapid test, whatever may be the test, regardless of their true own infection status. So NACO recommends the use of total nucleic acid test, the PCR, which basically, as I said earlier, on a DBS or dried blood spot sample of the infant to detect the viral nucleic acid, which detects proviral DNA as well as HIV RNA, and it's a qualitative test for diagnosis of HIV-1 infection during infancy. This test is performed at 6 weeks of age or at the earliest opportunity when the infant and the mother come in contact with the health delivery system or the healthcare worker. At or and after 6 months of age, the TNA PCR must be performed after screening for HIV antibodies. And for breastfeeding children, if they are tested 3 months, they need to be tested 3 months after complete cessation of breastfeeding or 18 months of age, whichever is later, to reliably exclude HIV-1 infection. As we all know that HIV can pass on through the breast milk. So it is said that if someone is breastfeeding, so after complete cessation of breastfeeding, after 3 months or 12 weeks, the TNA test has to be done, TNA PCR has to be done, or 18 months, whichever is later, to reliably exclude the HIV infection. Next slide, please. And this is a little bit about HIV. As you all know, large majority of our infection in our country is HIV-1 and globally also, except in West Africa, where HIV-2 is relatively common. HIV-1 has got 4 groups actually, M, N, O, and P. And amongst HIV-1, there are subtypes A through K, excluding E and I, and is 1, and HIV-2 has 5 subtypes, A to E. Next slide. These are all theoretical things. Next slide. So at times we are required, all of the ART centers probably come across such cases of HIV-2 diagnosis issues. So what is the guidance in this regard? So basically, you get patients or clients, they are referred from the ICTC to the linked ART center, whether co-located or the nearest ART center, with a report from the ICTC. So once the client comes to the ART center, we need to look into the ICTC report carefully. What does it say? If it says that the sample is found as only HIV-2 reactive by 2 differentiating test kits at ICTC, you know that the boxes are there. They mention about the name of the test kit, the batch number, and the result of the test strategy. So if it is reactive only to HIV-2 by 2 differentiating test kits, then it has to be taken as HIV-2 infection, has to be recorded, and ART has to be started, and no further testing should be done. This is important. If it is confirmed by 2 differentiating tests at the ICTC that is mentioned in the ICTC report, don't send the particular person to HIV for refer the patient for HIV-2 diagnosis. And as we currently we are using the TLD or dolutegravir based regimen, so which is equally effective against HIV-2, so there is no issue of concern. However, if the center, as we all know that HIV-1, for HIV-1 there is a viral load test facilities there, which is validated and is done through the program. For HIV-2, as of now, there is no validated or commercially available viral load test. So HIV-2 is monitored only through clinical and immunological parameters. Suppose the ICTC report mentions that this is found to be positive as HIV-1 plus HIV-2. So in that case, the patient has to be referred to the designated HIV-2 referral laboratory for confirmation. Or sample, it could be the other thing, the sample is found to be HIV-2 reactive by only one testing kit instead of two at the ICTC, then it should also be confirmed by referral to the HIV-2 designated referral laboratory. And we need to remember that for HIV-2 referral laboratory, they are established linkages are there. The patient has to go, not blood samples. Next slide. So this is the flow chart for referring the patient. The clients or patients with ICTC report, specimen is positive for HIV antibodies, HIV, either HIV-1 and HIV-2 or HIV-2 in one test only, along with a designated referral slip that comes from the ART center. It goes to the designated HIV-2 referral laboratory. There are, designated referral laboratory, and all ART centers must be knowing their referral pattern. And they, over there, they collect fresh blood sample and they test as per the national algorithm for HIV-2 serodiagnosis. And they report to the referring ART center, both hard copies as well as they mail the soft copy. And once the report comes to the ART center and the client, we need to hand over the original report to the patient and keep a copy as a record that this is a case of HIV-2 or whatever, if it differentiates result that comes. Next. So next issue is about the assessment of adults and adolescents with HIV infection, which you do every day at the level of the ART center. So actually you must be knowing much better than me. I'm just, I'll go through the slides. Next slide, please. What we do in the initial evaluation of PL-HIV, which is very crucial, considering that a person who is going to be there at the ART center for a prolonged period of time. So the initial evaluation is very important. So there are 3 steps. First step is the clinical assessment, and a thorough medical history recording is important. And the second 2 is a thorough physical examination involving all systems involved. And the third is baseline laboratory evaluation. So we go one after the other. So the first is clinical assessment and the medical history. Next slide, please. So in clinical assessment and medical history, the first and foremost thing that after taking the medical history and doing an assessment, we need to go for the clinical stage of the infection. We'll come to that, you all know. Then once again, we'll come for refreshing our knowledge and identify the current HIV related illness that may require treatment. This is important. What is the major health issue in this HIV positive person that which has brought the patient to the ART center? This is important that we need to identify that illness. If it is an acute illness, will he or she require an inpatient care, or can he be treated on an outpatient basis? That we need to do, and identify any prior exposure to antiretrovirals in the past, whether received antiretroviral drugs from the private sector or antiretrovirals in another ART center, and then he or she has migrated to another center, etc., or might have received single dose nevirapine in the past as a PPTCT program medication, or it could be post-exposure prophylaxis medicine, both occupational as well as non-occupational exposure, or it could be even pre-exposure receipt of antiretroviral. So we need to keep everything in mind and determine the need for opportunistic infection prophylaxis is important. When do you start quatermaxogyl prophylaxis, INH prophylaxis, etc. Identify coexisting medical conditions such as diabetes, hypertension, renal chronic kidney disease, chronic liver disease, or any other disease, heart disease, that might influence the choice of antiretroviral drugs. Determine the nutritional status of the individual and his or her needs, and elicit the history of past illnesses is very important, particularly of tuberculosis, sexually transmitted infections. These are all very important, as we all know, when those who work at the ART center level. And the another duty remains, that is to elicit the HIV status of family members or partners, or in other words, to assess the burden of HIV in the family is very important. Is it the only individual who is sitting in my phone with a positive HIV report is the only person infected in the family, or the lady standing beside him, she's also asymptomatically infected, or might be the children? So we need to look into the entire family and offer index testing for services for spouse, regular sexual partners, as well as and injection partners in case of people who inject drugs, and biological children. And also assess the need for psychosocial support. Uh, Try to assess the mental frame of the particular person, whether there is an evidence of depression, is there any suicidal ideation, is he very much anxious? All this we need to dig it out, particularly during the initial or the first visit. Next slide, please. So this is, if you go for the history, one is an HIV testing related history, and TB screening. You all know that for adults, we need to look for 4S screening with fever, current cough, weight loss, and night sweats. And for children, fever, cough, poor weight gain or reported weight loss, and history of contact with an active TB case in the family or close contact. In addition to TB screening, we need to look for other symptoms involving other uh, uh, systems, headache, poor concentration, seizures, and the general medical history for comorbid condition like hypertension, diabetes, heart disease, kidney disease, liver disease, etc. History of TB in the past history, as we discussed earlier also, and TB in the family. Prior exposure to antiretrovirals, we have already talked about it. History of sexually transmitted infections and its treatment received, if any. HIV risk behavior, like having multiple partners with unprotected sex with multiple partners, or that the person belongs to from the key populations, whether injection drug users, MSM, TG, and all truckers, migrants, all, and female sex workers, all we need to look into it. And also we should try to ascertain the history of substance abuse, not only alcohol, tobacco, etc., but also of oral and injection drug use in particular, since in certain areas the epidemic is still going through injection drug use through sharing of injection and other injection paraphernalia, syringe injection and other paraphernalia, as well as sexual contact through of these individuals. Pregnancy and contraception issues need to be discussed and all documented. Similarly, allergies, medications, vaccines need to be noted, allergens to etc. Nutritional status, as I said, has to be looked into, as well as psychosocial assessment. Next slide, please. There would be repetitions in subsequent slides as well, but if you look into the checklist, which is very important for HIV testing, you need to ask about whether the person was ever tested for HIV in the past. So in that way, you can ascertain that someone was infected in the past, when tested positive, and then started ART and stopped, and then he has posed as a new client before the ICTC kind of thing. So ever tested for HIV in the past? If so, date and place of the first HIV test. Is it in a private sector or a public sector? In the public sector, what was the reason for HIV testing? That need to be whether it was a self-referral kind of thing, or drop-in client, or it was initiated by some provider-initiated testing, or developed some medical illness, and the doctor thought of underlying HIV and referred. Documentation of the test result important, and the people will come across particularly from two kinds of people. The one is an orid well who go for repeated HIV testing, and sometimes from members of the key population, they are also subject, they also undergo repeated HIV testing. So date of the last negative HIV test result is important, and previous CD4 counts and viral load, if available, applicable and available, that has to be noted. And we all know about the HIV risk, has been documented here as well. Unprotected sexual contact, injection, drug use, commercial sex work, men having sex with men, occupational exposure, healthcare worker, perinatal transmission from HIV infected mother to infants, recipients of blood products, blood and blood products, multiple blood units, serodiscordant couple, etc. And review of the clinical symptoms: unexplained weight loss, swollen lymph nodes, enlargement of lymph nodes, whether due to TB or malignancy or lymphoma or cryptococcal lymphadenitis or secondary syphilis, all need to be looked into. Night sweats and fever due to TB or B symptoms of lymphoma, unusual headache, poor concentration and confusion, fever with chill and rigor, change in appetite, skin rash, whether a spontaneous or related to some drug, has to be ascertained. Nature of the rash, is it phthiritic or not? The site, how the rash evolved, what was the first site that the rash appeared, and what was the evolvement is important, whether associated with fever or not, or many other things that you need to look into. Sores and ulcers or white spots in the mouth, pointing towards oral candidiasis, painful swallowing, like esophagitis, candida, HSV, and then CMV, esophagitis, etc. Chest pain, cough, or shortness of breath might be due to PCP or even community-acquired pneumonia, abdominal pain. And we also need to think about COVID-19 these days also in the differential diagnosis. Abdominal pain, vomiting or diarrhea, numbness or tingling in hand or feet, peripheral neuropathies, which is also seen in HIV, advanced HIV disease, and due to some drugs as well. Muscular weakness or abnormal movements, partial loss of vision or visual field defects has to be looked into. And past history, like all HIV related illnesses, you need to ask and you try to document: oroesophageal candidiasis, persistent diarrhea, tuberculosis, varicella zoster or herpes zoster, oral hairy leukoplakia, and some of them are HIV, AIDS defining conditions like pneumocystis jirovecii pneumonia or recurrent bacterial pneumonia, cryptococcal meningitis, toxoplasmosis, particularly of the brain, Kaposi's sarcoma, disseminated MAC, CMV infection, particularly of the retina, and invasive cervical cancer in case of women. Next slide, please. Tuberculosis history we already talked about, but then again you need to go into detail history of past TB infection and type of TB, pulmonary tuberculosis or extrapulmonary. If it is extrapulmonary, whether it's a meningeal tuberculosis or TB lymphadenitis or abdominal tuberculosis, pleural effusion, etc. And if an old chest X-ray is available, then you need to go through, have a look into it and get it reported, whatever the lesions, and what anti-TB drugs the person has received, and the duration, the dose, all need to be documented. So also history of TB in the family or close contact, and the forest screening has to be done. Also the ART history, the current and the past exposure to antiretrovirals, particularly antiretrovirals used during pregnancy for PMTCT protocol earlier on when we used to use single dose nevirapine. So that is one important issue. And use of PEP in the past, post-exposure prophylaxis. It can be due to post-exposure prophylaxis following occupational exposure in healthcare workers, or it could be non-occupational exposure or foreign sexual exposure. Also, people take post-exposure prophylaxis medicines. These are also available to the market. So we need to ask all these questions. And current and past use of pre-exposure prophylaxis, you all know that now this has also been started in the country, particularly in the private sector. Number of people, doctors are also prescribing pre-exposure prophylaxis for people who are vulnerable. Drugs taken and for how long, these are all important. Which antiretrovirals were taken, for what was the duration. In understanding of the treatment and readiness to commence ART is very important, because the patient or the client is going to commit to a lifelong treatment. So the patient has to understand the nuances of the therapy and the benefit the person is going to have. Having ART lifelong is important. That has to be emphasized. And the partner, in case of concordant relationship, we need to look for the antiretroviral history is important. Similarly, STI, you look for genital ulcer or other lesions, genital discharge, whether it's a vaginal discharge or it's a cervical discharge, scrotal swelling, or urethral discharge or anal ulcers, lower abdominal pain, etc., might be due to PID. Substance use, we have already talked about alcohol, stimulant, opiate, use of other drugs, smoking, etc. And general medical history, we have already discussed hypertension, diabetes, coronary artery disease, hepatitis B, C, etc., hyperlipidemia, mental health issues like depression, etc., and allergies, known allergies to drugs, particularly drugs that we use commonly, like sulfur drugs. We use cotrimoxazole prophylaxis is important, or other substances or other material. Next slide, please. So continuing with the medical history checklist is a long list. Medications, past use of drugs and reasons for taking those drugs, current use of drugs and reasons, current use of traditional or herbal remedies, opioid substitution therapy for persons people who inject drugs. They are often for harm reduction. They are taken into OST for opioid substitution. Vaccination history in case of kids, BCG is very important, which is given usually at birth. In addition, hepatitis B vaccine is there. Hepatitis A vaccine is gradually is being promoted in the country, but hepatitis B vaccine is now part of the universal vaccination program. And as we go through this pandemic, we need to remember the COVID vaccination is also important from PLHIV. Gynecological history, the last pap smear, if it is available, the results, and the menstrual history, pelvic pain, discharge, etc., all need to be taken into account. Pregnancy and contraceptive history, previous pregnancies and MTP in the years, duration, children and HIV status of the children, as they're living as well as dead, if any, exposure to antiretroviral during pregnancy, drugs and duration of antiretroviral therapy, contraception, if used, what kind of contraceptives are used, last menstrual period is also important. Psychosocial history, family history, like other immediate family members with known HIV infection, social history, marital status, education, occupation, source of income, sorry, financial and family support status, disclosure status, like readiness to disclose. This is important at the ART center level, particularly for spouse counseling or partner counseling. The disclosure status, we need to assess the readiness, or we need to counsel the patient positively to promote disclosure among those who are susceptible. Availability of care and treatment supporter is important, as you must be knowing better than me that the most important challenge you face at the ART center level is basically the adherence issue. Next slide, please. Next. Next slide. So next is physical examination. Once you finish, so you understood that the importance of taking history on the first visit is very important, and that should be done thoroughly, carefully, and in a non-hurried manner. And the important salient features has to be all need to be recorded. Physical examination, general physical examination like pulse, blood pressure, temperature, respiration, body weight, height, particularly for children, and general point like anemia, cyanosis, condition. I think I lost my screen. Uh, I think Rajesh Datto is now sharing the screen, or Shweta, am I audible?
Yes, sir, you are audible.
But I have lost my screen. Praveen, are you going to do that for me now?
Shweta will
Please
do
give me
that,
two
sir.
minutes. So please give
Okay.
me 2 minutes. Yes, is the screen visible?
Yes, yes.
Sorry.
Right. So an examination of all lymph node sites are very important, not only cervical lymph node, but the axillary lymph nodes, epitroctal lymph nodes, inguinal lymph nodes, all lymph node sites need to be carefully examined. So also the importance of examination of the oral cavity and mouth is of utmost importance. With a good light source, one has to look, and many conditions can be just simply diagnosed by having a look inside the oral cavity. Examination of the skin and look for particularly for STI is important. All systems should be examined, but the initially probably is the as the patient presenting symptom often indicates the symptom where you need to go far fast. Otherwise, has to be all starting from respiratory system, upper and lower respiratory system, GI system, upper and lower GI system, neurology, cardiovascular, genitourinary, all system need to be looked into in great detail. Next. So next is basically, as we said, that the one of the important purposes of initial visit is to go for a WHO clinical staging. And as you all know, for adults and children, there are 4 stages. Stage 1 are essentially asymptomatic as well as persistent generalized lymphadenopathy, which is defined as enlargement of lymph nodes of more than 1 centimeter in size in 2 or more non-contiguous extrainguinal sites in absence of any etiology and persisting at least for 3 months. So the rule of 1, 2, and 3, basically that is the condition that should be is classified as PGL, and this is into the clinical stage. Next slide, please. Stage 2 in adults and children are almost similar with a little difference in children. Weight loss in of unexplained, unintentional weight loss of less than 10% of presumed or measured body weight. Recurrent RTI, particularly upper respiratory tract infections like sinusitis, tonsillitis, otitis media, pharyngitis, etc. Herpes zoster, angular cheilitis, recurrent oral ulceration, pruritic papular eruptions, fungal infection, seborrheic dermatitis. These are all in stage 2 in adults and children. In addition, you need to look into unexplained persistent hepatosplenomegaly, linear gingival erythema, extensive wart infection, extensive molluscum contagiosum, and unexplained persistent parotid enlargement, which is unique for children with HIV. So we need to remember that. And linear gingival erythema also a marker of clinical marker of immunosuppression in children. Next slide, please. And when you talk about staging in clinical stage 3 is actually advanced HIV disease, where the weight loss is more than 10% unintentional weight loss, or unexplained chronic diarrhea for at least for a month or longer, unexplained persistent fever, intermittent or constant for longer than 1 month, persistent oral candidiasis, oral hairy leukoplakia, pulmonary tuberculosis, and severe bacterial infections like pneumonia, empyema, osteomyelitis, bone and joint infection, meningitis, bacteremia, etc. These are all part of clinical stage. And children, you just see the difference in unexplained chronic diarrhea, where in adults it is longer than 1 month, but in children 14 days or more should be taken at stage 3 in a child who is known to be infected with HIV. In addition, the TB, you see that pulmonary tuberculosis is in adults is stage 3, but all extrapulmonary tuberculosis in stage 4 in case of adults, but in children, lymph node TB, particularly superficial lymph node TB and pulmonary TB are considered to be in stage 3. Next slide, please. Acute, continuing with other stage 3 conditions, acute necrotizing ulcerative stomatitis, gingivitis or periodontitis, unexplained anemia with hemoglobin less than 8 gram per dl, neutropenia, as well as chronic thrombocytopenia. Children, in addition, symptomatic lymphoid interstitial pneumonitis, as well as chronic HIV-associated lung disease, including bronchiectasis. These are actually unique to children with HIV as compared to adults with HIV. Next slide, please. The last is the stage 4, which is all the AIDS defining illnesses. So HIV positive and having this listed conditions of stage 4, they are actually having AIDS. So HIV wasting syndrome, which is defined as unintentional weight loss of more than 10%, along with either chronic diarrhea of more than 1 month duration or fever of more than 1 month duration, is taken as HIV wasting syndrome. Previously used to be known as slim disease in Africa when the epidemic initially started. And pneumocystis pneumonia particularly is one, stage 4. Recurrent severe bacterial pneumonia, chronic herpes simplex infection, orolabial, genital or anorectal of more than 1 month duration, or if it is of any viscera like liver, lungs, brain, etc., then it should be at any duration. So that is their chronic herpes simplex infection. Esophageal candidiasis or candidiasis of trachea, bronchus, and lungs. Extrapulmonary tuberculosis comes in this list. And children, unexplained severe wasting or stunting, this is important, or growth retardation or severe malnutrition not responding to standard therapy for malnutrition. Recurrent severe bacterial infections such as empyema, pyomacytis, bone and joint infection, and which were in stage 3 in adults, they are taken into stage 4. Next slide, please. Continuing with the list, Kaposi sarcoma, CMV infection, retinitis or infection of other organs, CNS toxoplasmosis, we talked about this earlier, HIV encephalopathy, extrapulmonary cryptococcosis, particularly meningitis, disseminated NTM or non-tubercular microbacterial infection, PML or progressive multifocal leukoencephalopathy, chronic cryptosporiosis, chronic isosporiosis. Next slide, please. Disseminated mycosis like extrapulmonary histoplasmosis in our country, coccidioidomycosis elsewhere is not seen in India. Lymphoma, either primary CNS lymphoma or B-cell non-Hodgkin lymphoma, symptomatic HIV-associated nephropathy or HIVAN or cardiomyopathy, recurrent septicemia including non-typhoidal salmonella, invasive cervical cancer we talked about earlier, atypical disseminated leishmaniasis is also considered to be in clinical stage 4. So you can see a large number of conditions have been listed as stage 4. Some of these conditions can be diagnosed at the initial evaluation at the ART center. Some of them would require a thorough investigation to arrive at a diagnosis, might require the patient depending on their clinical illness might be required to be admitted and then investigated and to arrive at a diagnosis. Next slide, please. So this is time for you use your chat box for the responses, like the clinical stage of the opportunistic infection. I think people are supposed to type in the chat box.
Yes, sir.
Okay.
Participants are requested to put their responses in the chat box. You can just say stage 1, 2, 3, or 4.
We can go to the next one. Oh, people are smartly answering appropriately. Next slide.
Can I go to the next slide, sir?
Yes, yes, please. Yes.
Should I take it from the first slide, sir, now? The quiz slide?
Yes.
Yeah. Yes, sir.
So what is the clinical condition here? Can someone, I don't know whether they can, herpes symptoms. Excellent, excellent. The next one, next slide. This one, herpes zoster. Excellent. And it's multidermatomal as well. This one, this one oral candidiasis. Good. The next one, here you need to, this is also oral candidiasis, but if you have a closer look, you will find that there is an extension into the soft palate as well as uvula. Of course, the posterior pharyngeal wall is not visible from this particular picture. So it could be an oroesophageal, oropharyngeal candidiasis. Whether there is an esophageal extension or not, that can be ascertained either being asking the patient to whether he or she is having, whether he is having dysphagia or difficulty in swallowing, or odynophagia or painful swallowing. And if there is extension into the posterior pharyngeal wall, you can take it as evidence of esophageal candidiasis. Why is needed to know that we need to differentiate between oral candidiasis and esophageal candidiasis? Because in oral candidiasis, a topical application might work, or if you use or systemic antifungal like fluconazole, the lower dose like 50 to 100 milligram once daily for shorter duration for 7 to 10 days is good enough. But if there is profound immunosuppression and if there is extension of candidiasis down the esophagus, you will require a higher dose of at least 200 milligram of fluconazole once daily for at least 2 to 3 weeks to get rid of the condition. And we all know that esophageal candidiasis is basically is a condition which is a stage 4 condition, and so we need to start antiretrovirals at the as soon as possible. And this, whenever you see a case of oral candidiasis, remember that you need to start cotrimoxazole on the same day, as this is a stage 3 condition. So as I said at the outset, that if you look into the uh, clinical examination of the oral cavity, will give you good clues when to start cotrimoxazole prophylaxis in addition to antiretroviral. Next slide, please. So this is, what is this? Can someone say? Yes, there's an cervical lymphadenitis, which could be the common conditions in our comes to tuberculosis that we need to remember. But we need to remember other conditions might present in such a way apart from TB lymphadenitis de novo or TB lymphadenitis iris is one. It could be due to other conditions. Could be due to non-Hodgkin lymphoma or even cryptococcal lymphadenitis. This can also be there. You need to remember. And there is an if it is an swelling, the swelling there is an extension from the parotid region as well. Thank you. Next slide. So that's this is important. How to do it? Triage our patients at the ART center. So we need to ascertain the signs of serious illness immediately and try and fast track the patient for clinical evaluation and, if required, a referral or admission as an inpatient for inpatient care. If the patient is having temperature more than 39 degrees Celsius with complaints of headache, respiratory rate, which might actually fever with headache, you need to keep meningitis in the back of mind, whether it's a cryptococcal meningitis or TB meningitis, it should be there. Although there could be many other causes, even sinusitis can also produce fever. Bacterial sinusitis can also produce fever with headache. But then again, we need to keep it in mind. If there a respiratory rate is hurried, 30 per minute or more, heart rate, if there is tachycardia, so there is the tachycardia, tachypnea, and these days all ART centers must be having pulse oximeter because of this COVID pandemic. If the saturation is less than 90%, so you need to be cautious. Altered mental status like confusion, strange behavior, reduced consciousness, etc. And other neurological problem, persistent severe headache, seizure or convulsion, paralysis, or difficulty in talking, or rapid deterioration of vision, unable to walk unaided. These are all clinical conditions which will require an immediate attention for starting appropriate treatment by either by referring or emergency management might require. Next slide, please. So that brings to the issue of advanced HIV disease. We know a package has also been mentioned about it. We'll have sessions on that. So what is advanced HIV disease? For adults, adolescents, and children older than 5 years, it is defined as a CD4 less than 200 or WHO clinical stage 3 or 4 event. And this includes, remember, both ARV naive as well as those who have received ARTs in the past and have interrupted treatment and returned to care later on. This is quite common, is not uncommon to see in ART centers. This has more happened during the pandemic also. People stopped antiretroviral therapy and then after some time getting sick, again coming back to the ART center. So in adults, it's a stage 3 or 4 or CD4 less than 200 for adults, adolescents, and children above 5 will qualify as advanced HIV disease, whether it's an ARV naive patient or ARV experienced as well as one who has interrupted treatment. And for children below 5, newly diagnosed children less than 5 years, regardless of their clinical stage and CD4 count, both absolute as well as percentage. Severe immunosuppression following treatment failure in case of children, re-engaging with the care after treatment interruption, whether symptomatic or not. So re-engagement with the care after treatment interruption, these are the 3 conditions in children below 5 we need to consider. So all children below 5, regardless of their clinical stage, CD4, etc. Severe immunosuppression following failure in children. And we need to remember that children older than 2 years of age who have been receiving antiretroviral for more than a year and stable on antiretroviral therapy and clinically stable, they should not be considered to have advanced disease because they are on antiretroviral. They have some, the viral load is also, if you look at the viral load would also be suppressed after 1 year of antiretroviral therapy in most of these children, and they are clinically stable and doesn't have any any active OI. So those cases may not be taken as advanced HIV disease. Next slide, please. Nutritional assessment is very important both for adults but most importantly for children with HIV. As we all know that BMI less than 18.5 is taken as one of the independent risk factor for morbidity and mortality in HIV positive adolescents and adults. This has been amply proved. So nutritional assessment has to be done and this has to be done very carefully. The weight, height in children has to be measured and weight has to be recorded in all visits. And in this context, we need to remember that we need to check our weighing machines as well. So also the stadiometer for measuring the height of the children. Assessment of edema is because edematous patients often swollen, the body weight might be artificially increased because edema is also seen. Bilateral edema is a marker of nutritional, often severe malnutrition. We see such patients, but other causes of bilateral edema has to be kept in mind into the differential diagnosis, including cirrhosis of liver with decompensation, the nephrotic syndrome, congestive heart failure, all their need should be there into the differential diagnosis. And the dietary or food history, this is important to modify the dietary requirements if PLHIV are deficient as per the recommended needs. Where there are nutritionists in the COE or PCOE, they can help. Even counselors have also been trained in their counseling through their modules, how to assess nutritional status and give nutritional counseling to the PLHIV or the care providers of the CLHIV. Next slide. Coming to the last issue of lab investigations, essentially hemogram or CBC, urine for routine and microscopic examination is important. So also a fasting blood sugar, blood urea, serum creatinine, serum bilirubin and ALT has to be there. So also VDRL or RPR, CD4 count and chest X-ray PFU. These are essential for all patients registering at the ART center. So all these investigations need to be done from the hospital where the ART center is located. Some center might not have the facility for CD4 count, but all other investigations are there. But one thing we need to remember that absence of such test results should or getting the reports on a much getting a longer date to get this test done should not stop someone to prescribe antiretroviral drugs. We at times come across cases where the patients have been diagnosed, registered at the ART centers, but the patients and the medical officers are waiting for the reports to become for the chest X-ray, for the sputum examination, for the ultrasonography, etc., or hepatitis B, C reports, etc. Please don't wait. Start antiretroviral therapy at the earliest, because now it is proven the earlier you start antiretroviral therapy, the better is the outcome for the client or the PLHIV or the CLHIV. Next slide, please. In addition to this, basic additional tests are often done, which is as per the discretion of the ART medical officer or the physician attending the patient. These are actually essentially symptoms and signs directed investigations to rule out OIs. Particularly TB exclusion is important for symptomatic patients. So sputum or appropriate specimen for CBNAT or TruNAT has to be subjected. And other investigation, ancillary investigations, it might be a pleural fluid analysis, it could be a CSF study, it could be an ultrasonography of the whole abdomen, or a lymph node fine needle aspiration. That has to be done for cytology as well as CBNAT or TruNAT for MTB detection. Complete LFT has to be done for client starting anti-TB treatment. And for those with hepatitis B and C co-infections, lipid profile, if available in the facility, USG abdomen, particularly presenting with hepatosplenomegaly or PUO, this is a good screening tool for diagnosis of multiple opportunistic infections. And in case of Kalajar endemic areas, arc-13 strip test, particularly Bihar, Jharkhand, Eastern UP and parts, few districts of West Bengal, patient presenting with PUO in evaluation, then you need to consider arc-13 also. And those who reside in those endemic areas or have history of travel to those endemic areas, the arc-13 strip test to look into the anti-leishmanial antibodies has to be looked into. Pregnancy test, we said, we discussed earlier, for women, cervical pap or other method of cervical cancer screening has to be done. For men having sex with men, anal pap smear if available. However, we need to remember non-availability or non-feasibility of any of these tests should not delay the initiation of antiretroviral therapy. As I said earlier, that all the above investigations other than the CD4 should be done from the health facility where the center is located with support from the state health department. So this is important that the hospitals housing the antiretroviral treatment centers should help the ART center by giving them access. And in fact, they should be prioritized. Being immunocompromised individuals, they should be prioritized. They should be given faster date, etc. Next slide. So this is basically essentially assessment and management of the patient at first visit. You do it on first visit, like registration, history, follow-up symptoms, 4S TB screening, physical examination, psychosocial assessment, assessment of education, social support, disclosure status, understanding of the individual regarding HIV, nutritional assessment, and family assessment, and the recommendation of safe sex practice, use of condom, and readiness or assessment or preparedness counseling, and the baseline investigations like essential tests that we have just discussed, cotrimoxazole preventive therapy, and starting antiretroviral therapy. We need to remember that all clients need to be started ART as fast as possible after just stabilizing the AYs as quick as possible, except in two conditions where ART is delayed. One is an TB meningitis, and the other is cryptococcal meningitis, where at least a wait for 4 to 6 weeks is good for the condition of the patient itself. Next slide, please. And and before follow-up visit, this is important. Within 3 to can I go back? Yeah, this is the last slide. Within 3 to 15 days after initiating ART, probably I don't know how many of the ART centers do this practice, that when you need to review the test results, if the results are not abnormal, then the patient has to be called back to ART center as soon as possible within 2 weeks of ART initiation is one. And the second and most important is that the counselor need to call to all patients who have been started on antiretroviral therapy to learn about the general well-being of the patients within 2 weeks of ART initiation, and whether the patient is having any early intolerance or side effect can be picked up. And more importantly, when a client sees that a counselor calls him or her up over telephone, the patient gets a confidence into the in that ART counselor. Says this is important, considering that counselor and client relationship is very important for a disease like HIV that we deal with in the ART centers. And subsequent follow-up visits are important, and everywhere you need ask for new symptoms, etc., whether the old symptoms have been ameliorated or not. And symptom checklist, as we have discussed earlier, a thorough clinical examination for symptom, TB screening, side effects, if any, and investigation as per the guideline, counseling and adherence assessment, and strengthening of assessment, adherence counseling every visit is of utmost importance. So I think I can stop here, and the next, and if there are questions, any burning questions, I can discuss, or you can mail it to me as well. We can answer later on as well.
Okay, sir. Any questions from the participants? If you can quickly take them, else you can email it to us or write in the chat box. So I don't think there are any questions. Thank you so much for facilitating this session. Thank you to all the participants for attending this session. Please note the next session will be on 23rd December. That's next Friday. The session will be held from 2 to 3 p.m. And the topic is ART in adults and adolescents and adherence to ART. All the senior medical officers and medical officers of the ART centers are requested to kindly fill in the pre-test and post-test forms. Links are being shared on email. Thank you. So can we conclude the session now?
Thank you very much.
Thank you, sir. Thank you.